Thank you for the opportunity to be here. It's a pleasure to be part of this meeting and to be part of the discussion. I should give a little bit of context to Wellpoint, because I have to say, before I started at Wellpoint, I didn't really know who their insureds were. So we're actually about to change our name, which will maybe hopefully make things a little clearer. But Wellpoint is the licensee for 14 of the state Blue Cross Blue Shield plans. So in most states, the plans are under the name Anthem. In some states, say like New York, it's Empire. But that provides, I think, a little more context. So we have approximately 36 million members across the United States. So I want to kind of, I think, the kind of just introduce the concept of value beyond the discussion so far, because as a payer, what we're thinking about is how to make, how to navigate the needs of our different stakeholders, which include not only your patients, our members, the providers, but also the employers and the patients when they have to select their insurance each year and pay their insurance premiums. And so when we think about care, we think about not only in terms of is it safe and efficacious, but what are the resources required to deliver this care, and how much is it going to require us to raise premiums next year to be able to continue to provide all the other care that people need. And I think, targeted therapy, has, and, by necessity, then the biomarkers have made a huge impact in several diseases. The one that always comes to mind for me is chronic myelogenous leukemia, where when I was a fellow, the issue was always, when do we transplant this person? Because they were usually, for the most part, asymptomatic, but they were a ticking time bomb, and once you transplanted them, they had a 40% chance of mortality often as a result of the procedure, and often lived with graft versus host disease afterwards, which was very debilitating. So when imatinib came along, as a therapy based on the BCR-ABL target, it really dramatically changed the lives of these people. And they now, for the most part, are able to live out what appears to be kind of their natural life expectancy if they didn't have the disease by continuing to take the therapy. On the other hand, many of our targeted therapies have not really had that same impact. But the cost has risen dramatically at the same time. So the slide up here, the graph actually is from Peter Bach at Memorial Sloan Kettering. And I think what's most astonishing about it is that it's actually a log scale. So if you look back in the 70s and 80s, the typical treatment was somewhere between $10 and $100 a month. And now we're looking at $10,000 plus a month for every treatment approved by the FDA. And at least in 2012, there was I need to update this because there was actually just a very good review published. But in 2012, only one of the treatments that were approved extended survival by more than 6 months, and 2 extended survival by 4 to 6 weeks at an average cost of $6,000 a month. So the question really is how do we incorporate the idea that there's tremendous variation in cost in our context of how to provide the most appropriate treatment for our patients. So now looking at another perspective, so how do we pay for oncology care? And there was a terrific report last year by this group about how to align the incentives for oncology care in order to achieve quality and affordability. And if we look at how we currently pay for oncology care on this pie chart on the left, you can see that for a typical practice, 2/3 of the revenue comes from the drugs. Now, this isn't to say that, I think sometimes this gets misinterpreted in the press that oncologists are greedy and they're making lots of money. The reality is, for a typical practice, there's 7 FTEs per physician. So it takes a lot of resources to provide care for these patients. So any effort to try to shift revenue away from margin on drug for the practice is going to have to make up that revenue in some other way if they're going to be able to continue to provide care for patients. On the right-hand side, you see the view from the health plan. And this is where the dollars go for treating patients in active treatment. So this is actually any patient with a cancer getting treated with either radiation, surgery, or chemotherapy, or any combination thereof. So I want to emphasize that because this is not everyone getting chemotherapy. If we were to just focus on chemotherapy patients alone, this would actually look different. But just looking across any treatment for people in active treatment, the costs of chemotherapy, targeted therapy, and supportive care drugs are a quarter of the cost. So it's a big part of the puzzle, and it's rapidly growing, as we heard. So, this is, when we've been asked about, well, why are you focusing on drugs and why are you focusing pathways kind of initially on chemotherapy, this is the reason. Oh, before I switch, I just want to say the other part that I want to just emphasize is that the physician visits, or kind of what those of us in here who went to medical school to do, represents only 3% of the cost. I usually open my talks with a slide that emphasizes how much we spend on healthcare. So the typical family now has, in terms of their cost, their employer's cost, and their out-of-pocket costs, is spending about $22,000 a year on healthcare in the United States. And our median income is just over $50,000. So we're currently spending about half of our income on healthcare for a typical family. So we don't imagine that there's going to be that much increase over the next few years in terms of how much additional resources we're going to be able to devote to healthcare in this country. So in that context, if we don't figure out a way to be more, I guess, conscious of whether or not the resources we're spending in each of these buckets is really contributing to greater value for patients and better outcomes, then we're going to continue to squeeze out how much we spend on visits and patient-centered care. So it was great to have Bill go first and talk about the NCCN guideline process. And I think, we've all come to really rely on the NCCN guidelines. But one of the challenges, I think, both for clinicians as well as payers, is that they are very, very broad and inclusive, which is their strength, but also in some ways their weakness. So if you look at the NCCN guidelines for lung cancer, if you're just focusing on first-line therapy for patients with non-small cell lung cancer who don't have a mutation, there are 64 different treatment options that would meet the NCCN guidelines. So the question is how do you decide, even as a clinician, between those? So here is a slide summarizing the outcomes for 6 of the more commonly used, probably even though they're not necessarily designated by NCCN as the best, they're the ones that usually kind of rise to the top of different discussions. So you can see that the estimated survival of these regimens ranges from 13 months for treatment A. Treatment B is around 10.4 months with a confidence interval of 9.6 to 11.2 months. But you can see that they all range in the realm of a year, give or take. And some of the variation has to do with how recently the studies were done. Grade 3 and 4 adverse events are pretty similar across the regimens. The biggest differences have to do with the rates of neuropathy or grade 3 and 4 fatigue. And then, one of the things that, as I've been out talking to patients and advocacy groups, one of the things that's really challenging about the way that we present our data in trials is that it's very hard to figure out the patient-level incidence of adverse events. We capture adverse events as a unit, but you don't really know whether the grade 3 dehydration and the febrile neutropenia and the diarrhea all happen in the same patient or were 3 different patients. And most trials don't report their hospitalization rates, which would give you another sense of the impact of the adverse events. So, there may be major differences, but it's very hard to tell from the clinical trial data whether there are. They kind of blur together because of that. And then finally, I think another important outcome to our patients, which I don't think we normally include in our discussions, is the deaths while on treatment. Now, some of this is due to variations in the populations being treated, but the number in parentheses represents the deaths that were attributed by the investigators to the treatment. And you can see there's some variation there. And you might think that a patient might want to know that, for whatever improvement in survival they got with treatment E compared to the comparator in that trial, they had a 4% chance of dying in the next few months compared to less than 1%. So I would argue that those outcomes are not that different. And here's the difference in cost. So it ranges from $450 to carbopaclitaxel to $65,000 for carbopemetrexed bevacizumab. So largely as a result of variations like that, as well as the variation that we see in the quality of care and in adherence to guidelines in the first place, clinical pathways have become an approach that a number of organizations have pioneered. US Oncology was probably the first organization to develop pathways and implement them across their institution. And US Oncology, as kind of the leaders in this field, have published their data. So this is their outcomes data on patients treated on their pathway for non-small cell lung cancer. Now, their approach, since they were an organization of physicians, was a little bit different than some of the other pathways approach in that they actually got down to a single regimen as the pathway. So it was not several options, but they actually got down to a single regimen. And then my understanding is to treat someone off pathway, the treating physician had to get one of their partners to co-sign their orders, to agree with them that this was a reasonable thing to do. And you can see that the survival curves are superimposed. There was no difference in survival for patients treated on and off pathway, but patients treated on pathway had about a 30% decrease in the cost at 1 year. So since that time, there's been a proliferation of pathway developers with multiple business models. So two probably of the most well-known pathways, or the ones that have been implemented in the most settings, are that developed by McKesson Specialty Health, which has been supported by NCCN and done in collaboration with NCCN, as well as Cardinal Health, which acquired P4, which was one of the original programs that started working with health plans and oncology groups. New Century Health is a kind of a utilization care management organization that has developed pathways as well. Via Oncology, also kind of a spinoff of, I should have mentioned, US Oncology is part of the McKesson NCCN collaboration since McKesson acquired US Oncology. And then another spinoff of US Oncology actually was several of the principals went to UPMC and then started Via Oncology. So we see kind of similar origins for a number of these programs. So their model is more to work within healthcare systems and to have the provider groups and healthcare systems implement pathways through their EHRs. And then US Oncology still has their own program, although as I mentioned, they're largely now through their development processes through the McKesson collaboration with NCCN. And then there may be others, but I believe that Wellpoint is the only payer that's really gotten involved with developing pathways. And I'll explain to you in a moment why we decided to take this on ourselves. So we actually looked at partnering with the different organizations that have developed pathways. It certainly wasn't an undertaking that we really wanted at first to take on. But there were several key things that we wanted to ensure. First of all, we wanted them to be publicly available and out on the web. And at least up until now, the other pathways developers have considered their pathways their intellectual property and don't really want to make them publicly available. And so that limits the transparency, at least in our view. The other thing was that the other pathways developers also, for the most part, their business model is largely supported by the software that they use to disseminate the pathways. And as a large health plan, we have our own platforms that integrate with our claim system that allow things to be automatically approved. And so any additional software package would have been very cumbersome to work with and would have required lots of manual workarounds, both on the providers as well as on our side. So we began a process that I think is similar to, probably looks very familiar to most people who've been involved with developing evidence-based guidelines or other approaches. And it starts from basically national guidelines like NCCN and ASCO, as well as the data on from trials, publications, compendia. I mean, we really are, I would say, different groups, well, I'll show you on the next slide sort of the methodology. It's not always clear what levels of evidence the groups are that are using developing pathways. Our approach has been to say that we're relying on peer-reviewed evidence so that it's transparent and everyone has access to the same information we do. There's an internal team of oncologists and pharmacists that review the evidence and summarize it into tables with a little bit more detail, but look a lot like the tables that I shared with you on clinical benefits, side effects, and toxicity, strength of national guideline recommendations, and then finally the cost. And then we have a team of external advisors that come from academic medical centers as well as community practices, and they provide input on the pathway development. Our goal to them is to have pathways that are applicable to 80 to 90% of patients in that clinical situation. The evidence and literature is reviewed at least quarterly, so any changes to guidelines or any new FDA approvals, as well as changes in the average sales price cost data is updated quarterly, so that's all reviewed quarterly, and then any changes would be made at that time. We also can review things more quickly, but again, I'll get into the incentive model. The pathways are a voluntary program, and we have a carrot approach to their use, but there's nothing to prevent anyone from prescribing a regimen that's not on pathway. And in fact, we acknowledge upfront that we would expect 10 to 15% of patients to be not on a pathway regimen and be receiving the most optimal care. The pathways relevant to this discussion is that the pathways are specific to tumor type biomarkers and patient characteristics. And this is a screenshot of the web portal where the practice would enter the information to help determine if the patient was being treated with a pathway regimen. And so you can see that this is for a breast cancer patient, so you can see it includes the histology, the stage, the different biomarkers that are relevant to breast cancer. You're not required to report anything, so we're not specifying that you have to do a test. So you can see here, Oncotype DX wasn't done, so it's just entered as not reported. And then line of therapy and performance status. And then there's decision support that's provided based on the biomarkers. So based on the data, so the workflow is that the practice actually would have already selected a regimen, and their non-clinical staff would have entered that and then entered the clinical data you just saw. But the next step is that they do receive this screen back saying, based on the data you entered, here are the regimens that would be appropriate for this patient. Do you want to consider any of these instead of the one you entered? And the first 4 up there have a little check mark next to them, which indicates that they're on pathway. The others reflect, the evidence that would be largely based on NCCN, ASCO, and other guidelines, so other evidence-based regimens that would be appropriate in that situation. So here's a comparison of the different pathway developers that I highlighted previously, and just looking at a number of different criteria. So, I'm sure this can change. I went out and reviewed their websites in anticipation of this talk to sort of see what was available, as of last week. So looking to see if they describe their methodology. It may not be in as much detail as you would like, but is there some description of the approach that's used? Is there a description of the governance model in terms of how decisions are made? Are the committee members named? And are the pathways publicly available? And so you can see that for most of the pathways, there's very little description about the methodology or governance. I would say McKesson and NCCN have done the most rigorous, they have the most information available. The only thing that's not available, I think, from their pathways at this point is that they're not publicly available. And we also have tried to have a similar level of transparency. We make our pathways available. The one thing that we've been criticized for is that we don't name our committee members. And this is a challenge. If you this is just a handful of the things you can find on the web, but once people are named publicly, they tend to become quite popular among the various interests that want to ensure that their approach is considered, or their therapy or test is considered as part of the pathway program. And so, across Wellpoint, not just for pathways, but if you look at our medical policy committees and our P&T committees, the members of those committees are not publicly released because of the kind of lobbying or harassment that they would be subject to. So our approach is through the Pathways program is a quality initiative. So we see this as a framework for promoting high quality care. As I mentioned earlier, the pathways do not affect coverage decisions. So our coverage decisions continue to be based on our medical policy. Physicians selecting a pathway, though, are eligible for additional payment for treatment plan and care coordination. So our view on this is that up until now, for the most part, treatment plan and care coordination has been supported in practices on the profit margin on drugs. So if we're trying to encourage practices to, on average, practice in a more value-conscious way, we need to be able to have a way to provide additional support for treatment plan and care coordination. And so this fee is designed to basically keep the practice whole as they move towards more value-conscious care, and ideally have them come out a little bit ahead. And then lastly, even though this is not a prior authorization program, we did not want practices to have to be going to one place to request prior authorization for drugs and a second place to participate in the quality program. So we've integrated the prior authorization process into this platform so that practices come in, they enter the drugs they want to use, the clinical detail. As long as criteria match up, they're not trying to give Herceptin to a HER2 negative patient, they actually get their authorization right there after they've entered in the information, as well as feedback as to whether or not the regimen's on pathway. The website up there, it's a long title, but it's the name of the program. It contains all the information as well as all the pathways, and it's updated as soon as we release a new pathway. So the enhanced reimbursement basically for treatment plan care coordination is really for those pathway regimens that are clinically effective, and that's the most important thing, is first and foremost, the advisors help us to select those regimens that are most clinically effective and have the most favorable favorable side effect profiles, and then finally, when there are multiple options available, the most cost effective. The additional payment is $350 a month. So if you think about a regimen that costs $5,000 a month at 6% of the average sales price, the margin to the practice would be around $400. If you're looking at a regimen that's say $500 or $100 or $1,000 a month, the margin to the practice is $30, $40 a month. So the idea here is to basically level the playing field so that the choices can be made primarily on the clinical basis and not be, practices are not penalized for practicing cost effectively. And this is a visual of this. So for those 6 regimens that I showed before, on the left here, you see what the reimbursement would be typically through Medicare or our states where we don't have the pathway program in place yet. So the yellow bars at the bottom are what the typical reimbursement is for the visits. The light green bars represent the reimbursement for the chemotherapy administration, the CPT codes for hanging the bag and putting in the IV. And then the dark green bars represent the margin on the drug or the typical profit to the practice. So you can see for carbopaclitaxel, basically the practice makes essentially no margin whatsoever on the drug. And in fact, with the fluctuations in the price, could easily be losing money at any given point in time. But for the regimen on the right, the margin for 3 months of therapy or 4 cycles is around $4,000. You see the impact of adding the S code. And essentially, it increases the overall average reimbursement to the practice from $3,000 to $3,900, but the standard deviation across the regimens goes down. And so you can see that, you know, it's not possible to kind of equalize every single regimen, but the idea is to try to provide a way for practices to practice cost effectively and to keep them whole. So in summary, guidelines are very broad and often do not provide enough guidance to select the most effective treatment. Wellpoint's cancer treatment pathways focus on treatment options that are clinically effective, have favorable side effect profiles, and are cost effective, and pathways must be tailored to biomarkers and other key patient characteristics. Thank you.
Thanks, that was great. So moving right along, we're now going to hear about the adoption of genomics in oncology care. Nice small topic there. And we're very fortunate to have Catherine Phillips, who's Professor of Health Economics and Health Services Research at the University of California, San Francisco. And she's also the founder director of the UCSF Center for Translational and Policy Research on Personalized Medicine. And she's going to talk to us now.